Yeah, he have done the MD in internal medicine from R&T Medical College, Udaipur. He have done DM in endocrinology from AIMS, New Delhi in 1994. He has published 32 papers in various national and international journals. He is the recipient of Young Scientist Award by API during 1992. He is also the recipient of Dr. Naresh Bu Oresa Pioneer Star SFDI in 2017. He has got a lifetime achievement award by Diabetes Welfare Society Jaipur in 2018. He has received lifetime achievement award by Knowledge Forum in 2019. Currently, he is working as a senior consultant and director at the Institute of Endocrinology and Diabetes in Srajan Hospital, Udaipur, Rajasthan, and professor of medicine in Ananta Institute of Medical Science, Udaipur. He has organized several national and state conferences also. Over to you, sir.
Thank you. Can I please allow me to share my slides?
Yes, sir, please.
Can you see my slides?
No, sir.
Hello?
Not yet.
Can you see my slides now?
Yes, sir. But it's not full screen
Yeah,
yet,
I'm
sir.
making it full screen. Yeah.
Yes.
Can you see the slides now full screen?
Yes, sir. Yes, sir. Please.
Okay. Yeah. Thank you. Thank you very much. Good afternoon, everyone. At the outset, my sincere thanks to Dr. Bakshi Bhai for inviting me to this prestigious conference. Dear chairpersons and friends, I would be talking about a clinical topic. Non-diabetic nephropathy in diabetic patients. When to suspect? Okay. So, dear friends, it is a well-known fact that diabetic nephropathy, a leading microvascular complication of diabetes, is a devastating complication of diabetes leading to a lot of morbidity and one of the important cause of end-stage renal disease worldwide. In fact, diabetic nephropathy is a chronic condition developing over many years, and it is characterized by typical clinical course, the biochemical abnormality and histological abnormality. Say there is a gradually increasing urinary albumin excretion accompanied by the rising blood pressure. There is a decline in GFR, and while you make a diagnosis of diabetic nephropathy, obviously you have to rule out other non-diabetic renal diseases like urinary tract infection and so many other conditions which can develop in a diabetic patient. And commonly, diabetic nephropathy is associated with development of other microvascular complications, especially diabetic retinopathy, which is well documentable, well clinically characterized. So before I talk about non-diabetic nephropathy, I'll give you an overview of some of the clinical points which will help us in differentiating diabetic nephropathy from non-diabetic nephropathy. So non-diabetic kidney disease is basically a kidney disease developing in a diabetic patient independently from the diabetes related to diabetic factors. It's a common disease in type 2 diabetic patient. And why we want to differentiate, why we want to diagnose non-diabetic renal disease in a diabetic patient is because this has got a significant impact on prognosis and treatment, which is totally different from diabetic nephropathy. In fact, non-diabetic renal diseases, when picked up early in the course, they have a better prognosis and they are treatable in contrast to diabetic kidney disease. So why we want to make a diagnosis? Here you can see in this particular study, there were three groups characterized in diabetic patient. One was non-diabetic renal disease in diabetic patient, other was diabetic nephropathy, and third group was non-diabetic renal disease developed over a background of diabetic nephropathy in diabetic patients. And you can very well see the cumulative renal survival over a period of 1 year, 2 year, or 3 year was much better in non-diabetic renal disease as compared to diabetic nephropathy or patient developing non-diabetic renal disease in diabetic nephropathy over a background of diabetic nephropathy. So we really want to make a early diagnosis to pick up non-diabetic renal disease, which may a number of them may be treatable, and you improve the outcome. So the causes of end-stage renal disease in diabetic patients, as I mentioned, good number of patients have diabetic nephropathy as a cause of end-stage renal disease in type 2 patients, while good number of them may have non-diabetic renal disease, which include primary renal diseases, ischemic nephropathy, renal artery stenosis, some embolism, benign nephrosclerosis, or some other renal injuries. So broadly, the diseases can be various types of glomerulonephritis, say RPGN, chronic interstitial nephritis, acute interstitial nephritis, diffuse proliferative glomerulonephritis, focal segmental nephritis, IgA nephropathy, membranous nephropathy, and likewise. So there are a number of conditions which can develop in a diabetic patient and have a different prognosis. The literature from worldwide shows that almost 30 to 40% diabetic patient can have non-diabetic kidney disease. And here I'm sharing some of the Indian studies which are based on the biopsy proven causes of CKD, which are non-diabetic kidney disease in diabetic patient. And this says that some 25 to 60% patients of type 2 patients can have kidney disease not related to diabetic kidney disease. And some for 40 to 60% patients have diabetic kidney disease, and some one-third patient can have non-kidney diabetic disease superimposed on a background of diabetic kidney disease. So the prevalence of NDKD or non-diabetic kidney disease in a diabetic patient is very high. So before I discuss what are the pointers, what are the clinical markers, or what can be the clinical clues to suspect a non-diabetic kidney disease in a diabetic patient, let's understand, and I would highlight some of the important points of diabetic nephropathy, which will help us in differentiating non-diabetic kidney disease. If you review or you watch the natural history of diabetic nephropathy, diabetic nephropathy passes through various stages, which evolves over a period of years. Stage 1, stage 2, stage 3, stage 4, stage 5. And at each stage, there are biochemical abnormalities, there are clinical abnormalities, there are histopathological abnormalities. Say, for example, in the early stage, stage 1, which is hyperfunctioning or hypertrophic kidney, which can be well documented in type 1, but not in type 2, characterized by glomerular hyperfiltration. And at this stage, blood pressure may be normal and there is no albumin excretion. In stage 2, there is histopathological changes takes place, microalbuminuria sets in, and some patients can develop hypertension. While in stage 3 and 4, there is a clear increasing albumin excretion, hypertension sets in, and the histopathological changes worsens. There are typical changes. I'll not go in details. And end-stage renal disease is characterized by hypertension, marked. There may be albuminuria or albuminuria may vanish by this stage, and patient can have frank, clinical features of uremia. Some of the patients may not develop albuminuria; they directly, reach the stage of sclerosis and uremia. But this is the typical, stages, and we see in our clinical practice. So the progression is important to differentiate it from non-diabetic kidney disease. And as I mentioned, it takes years, and the maximum number of cases were seen to progress over a period of 10 to 20 years. So there is a progressive decline in the renal function, rising hypertension and other features, which evolves over a period of 10 to 20 years. Why so? Why it is important? Because any kidney disease which evolves rapidly, one should suspect that it may not be diabetic nephropathy. Similarly, there are typical pathological changes which develop in glomeruli of patient of long-standing diabetes before there is appearance of microalbuminuria. In fact, the severity of glomerular damage is proportional to GFR. So more the histological changes, there is a decline in the GFR, and this is proportional to degree of hyperglycemia, duration of hyperglycemia, and other risk factors. The main pathological changes in diabetic nephropathy are well known to us. The changes in GBM, glomerular basement membrane thickening, the typical KW lesions, diffuse glomerulosclerosis, interstitial fibrosis, and ultimately hyalinized kidney. So, dear friends, let us understand which are the clinical indicators which would suggest non-diabetic kidney disease in a diabetic patient. There are some well-established indicators. Let's say, for example, absence of diabetic retinopathy. And I'll come to this point again. But if there are no changes, no other macrovascular complication, especially if retina is normal, one should look again at the cause of renal disease in a diabetic patient. If the duration of diabetes is short and still patient has progressive kidney disease, one should revise the diagnosis. If there are microscopic, findings like hematuria, pyuria, cast, broadcast or WBC cast, then again one should think that it is not diabetic nephropathy. Then the nephropathy, there is a marked proteinuria, either rapidly developing nephrotic syndrome or the nephrotic range albuminuria, and likewise. If the HbA1c has been normal, patient blood glucose, blood pressure has been normal, still patient develops kidney disease, one should look at the other causes other than diabetic nephropathy. There are other potential indicators. Say, if there is no family history of diabetes, if the serum protein levels are high protein, high albumin, maybe you are dealing with some other type of nephropathy, immunoglobulin mediated nephropathy. Higher hemoglobin, higher serum creatinine, lower blood pressure. I mean, the blood pressure is not concomitant with the progression of the diabetic nephropathy. Abnormal complement level, abnormal IgG, and normal cystatin C level. They suggest that one should revise and one should look at the cause of diabetic, renal disease other than diabetic nephropathy. There is a very interesting association of diabetic nephropathy and retinopathy. Retinopathy has easily recognizable clinical manifestations and almost always precedes the clinically manifest signs of nephropathy in a given patient. There is a strong association between severe retinopathy and presence of KW lesions. So according to the guidelines, etiology of kidney disease in most patients with diabetes type 1 should be ascribed to diabetes if there is a pathological proteinuria and retinopathy. Simplifying this statement, in a type 1 patient, if there is a proteinuria and retinopathy, one should presume and one should take it for granted that you are dealing with diabetic nephropathy. Other way around, if there is no retinopathy, no proteinuria, still there is a kidney disease, one should revise that you may be dealing with non-diabetic kidney disease. So the association of retinopathy with nephropathy is very strong in type 1 patient, while this is not so in type 2. In fact, 50% of patients, 50% of type 2 diabetic patients can have diabetic nephropathy without frank diabetic retinopathy. And 40% of patients with diabetic retinopathy had non-diabetic nephropathy either alone or on a background of diabetic nephropathy. So the association of retinopathy and nephropathy in type 2 is weaker, but still, if you don't find retinal changes, one should revise the diagnosis, and one should have a second look at the diagnosis of the cause of renal disease. Duration of diabetes is important, I mentioned earlier, because longer the duration of diabetes, more are the chances of individual developing diabetic nephropathy. So, in fact, based on the literature, the reports even provide a relatively specific time period, and as per the hints or the recommendation, a duration of diabetes less than 5 years from the time of diagnosis of diabetes, developing kidney disease, one should think of non-diabetic kidney disease. So shorter duration of diabetes, still you have kidney disease, one should think of non-diabetic kidney disease. Again, a duration of more than 10 years is an important indicator of diabetic kidney disease. So longer the duration, one should think in terms of diabetic kidney disease. There are several studies which have individually studied the duration, the glycemic levels, the microscopic hematuria and other findings with the diabetic kidney disease and non-diabetic kidney disease. To summarize this particular study, which is Indian study, which highlighted the role of duration of diabetes and absence of retinopathy in type 2 patients. The conclusion is shorter duration of diabetes and absence of retinopathy, especially when associated with nephrotic proteinuria, strongly predict non-diabetic renal disease. Other, Korean study where correlation of hematuria was studied, and they say that shorter duration of diabetes, absence of retinopathy, and presence of glomerular hematuria were indicators of non-diabetic kidney disease. This is a Chinese study, again, absence of diabetic retinopathy, shorter duration diabetes, lower HbA1c were identified as useful clinical predictors of non-diabetic kidney disease, and one should think of non-diabetic kidney disease. There are no specific biochemical markers of diabetic nephropathy which would differentiate, though there are theoretically TGF beta, vascular endothelial growth factor, and other factors which are which are commonly found that to be raised in diabetic nephropathy. But albuminuria remains the only biochemical marker acceptable for diagnostic purposes. So once you suspect non-diabetic renal disease, we should go and perform the renal biopsy to establish the diagnosis. So the clinical markers could be nephrotic range proteinuria or nephrotic syndrome without retinopathy, kidney function alteration without retinopathy, nephrotic syndrome with shorter duration, nephrotic syndrome discordant with normal creatinine clearance, acute renal injury which is unexplained with diabetes, unexplained hematuria and other microscopic features, and rapid deterioration of renal function. When you have these, you should go for biopsy. So studies identified that renal biopsy is recommended for patients with type 2 for accurate diagnosis under these circumstances when you have well-established indicators and potential indicators. Before I summarize, and I would say that there are other renal diseases which are more common in diabetic patients. Say renal artery stenosis is twice as common in diabetic patients as compared to better population, and this contributes to kidney disease in diabetic patients. Diabetic patients are more prone to acute kidney injury, maybe or the AKI, because the pre-renal causes ATN or ischemic nephropathy and lifestyle. So one should keep in mind diabetic patients are more prone to acute renal injury. Well-known fact that diabetic UTI is more common and more severe in type 2 patients. Ascending urinary tract infection, upper urinary tract infection, pyelonephritis, acute chronic pyelonephritis, prostatic abscesses, emphysematous cystitis, pyelonephritis, intrarenal abscesses, papillary necrosis, septicemia. They are more common in diabetic patients and may contribute to non-diabetic renal disease. Bladder dysfunction are again a part of autonomic neuropathy and contribute to nephropathy. Obstructive neuropathy may be because of strictures, polyurethritis, bladder dysfunction, or papillary necrosis are more common in diabetic patients and may contribute to non-diabetic renal disease. So, dear friends, I would say that diabetic nephropathy is not the sole renal disease in diabetic patients. Various renal conditions can be found in diabetic patients, either superimposed upon this condition or independent from diabetic related causes. Renal biopsy studies suggest that some 25 to 50% of patients, type 2 patients, had glomerular lesions unrelated to or in addition to diabetic nephropathy. In contrast to type 1 diabetes, the incidence of non-diabetic renal disease is very high in type 2 patients. So non-diabetic renal disease is more common in type 2 patients. Therapy and prognosis of diabetic nephropathy and non-diabetic renal disease are quite different. Therefore, differential diagnosis of these two entities in diabetic patients is of considerable importance. As diabetic nephropathy does not have any specific therapy, identifying these non-diabetic renal disease conditions, which will give an opportunity to treat reversible conditions, thereby helping renal protection and improving the outcome. So I would again emphasize on the clinical markers. If there is no retinopathy in type 1, you should revise. Type 2 patient also, you should look at the retina. Renal disease of shorter duration, less than 5 years, or after 30 years of diabetes, if there is an onset of nephropathy, one should revise. If there is pyuria, hematuria, WBC cast, there is a rapidly progressive proteinuria, rapidly declining renal function, acute nephrotic syndrome, acute renal failure, or macroscopic hematuria, one should look at and suspect that you are not dealing with diabetic nephropathy. Appropriate investigation is required so that you improve the prognosis and outcome in a diabetic patient. Thank you very much.
Thank you, sir.